Hello students, welcome back to my channel. So today we will be learning a very important topic, that is pre-invasive cancer. You know, this is second most important ranking cancer all over the world in females. Now I will tell you the epidemiology of CA cervix first before we actually begin the topic. See, around 5 lakh cases are reported annually globally, and in India alone 1,30,000 cases are reported per year, with a death of 70,000 cases every year. So see, Indian female cancer attributes about 50% of the cases per year. So how much it is prevalent in India alone? It has been found that ICMR reported it that 13 to 24 lakhs cases per year are prevalent in India. So this is the very dangerous, alarming figure. So if we study the topic in details, it would be better for the patients if we can pick up the cases in the early stages. So we will be studying all details beginning with the cervical anatomy, metaplasia, at the transformation zone. And then you should better understand with the squamous columnar junction where changes takes place, then actual cervical intraepithelial neoplasia, when it is not treated, how it changes into cancer cervix. So we will study now. Let's begin.
Yes, dear students, we'll begin with our topic, cervical intraepithelial neoplasia. It is also termed as cervical dysplasia, and one more terminology nowadays it has been used for this is a pre-invasive cancer. What is cervical anatomy? We will see histological anatomy. The cervix is lined by columnar epithelium in the endocervix, which is the inner part of the cervix. And stratified squamous epithelium covers the ectocervix, or we call it as an exocervix. So these two epithelium, when they meet each other, the point at which they meet, it is called as squamo-columnar junction. The whole theory, whole changes, everything takes place at the squamo-columnar junction. So we will understand first what is this area. It rarely restricts to the external os. Instead, it is a dynamic point that changes in the response to puberty, pregnancy. See, there are hormonal changes takes place in the puberty, also in the pregnancy, and at the menopausal period. So according to the change, this squamo-columnar junction also changes a bit. In neonate, it is located on the ectocervix. Whereas in menarche, due to production of hormone estrogen, which causes vaginal epithelium to fill with glycogen. And in response with glycogen, this junction is again shifted further upwards. But you know, lactobacilli, these are the vaginal floras. It acts on the glycogen, it lowers the pH of the vagina, also of the cervix. It stimulates the subcolumnar reserve cells to undergo into metaplasia. These reserve cells we'll see in figure. These are just beneath the columnar epithelium and they have a tendency to exchange the places. See, this is the original squamo-columnar junction. If we see, this is the cervix, ecto and endo part. This is the endocervix. This is the outer ectocervix. And the change we see it is at the squamo-columnar junction, this dotted line. And this junction, this area is known as the transformation zone. I hope you understood. When stratified squamous epithelium replaces the columnar epithelium due to under the effect of some infection or any pathological change, or vice versa takes place, when columnar replaces the stratified, this whole thing occur at the transformation zone. And if these atypical types of cells varies in number and size, then we call it as a atypical cellular metaplasia. So this is columnar epithelium and this is original junction. So we will see properly the histological appearance. See, these are the stratified squamous epithelium and these are the columnar epithelium. You can see there are reserve cells beneath the columnar epithelium. And this squamo-columnar junction, This is ectocervix. This is the transformation zone. See, this is the junction where these two cells meet. Normally, in the full thickness of cervix, we see there is basal cells, parabasal cells. These are the intermediate cells and superficial cells. So normal, if there is no pathology, this whole arrangement we can see in histology. But when there is a change, this metaplasia, then what exactly is the metaplasia? It is the squamocolumnar junction is a labile transformation zone. The reserve cells lying beneath this junction form the metaplasia in the transformation zone, and these cells usually transform into mature epithelium, and this mature epithelium in some instances become atypical. We call it as a dysplasia. First of all, see the definition. What is dysplasia? It is a cytological term used to describe cells resembling cancer cells. Cervical intraepithelial neoplasia refers to histopathological description in which a part or a full thickness of stratified squamous epithelium is replaced by cells showing varying degrees of atypical cells. We call it as a dysplasia. But students, you should always remember there is an intact basement membrane in cervical dysplasia. Epidemiology, I have already discussed in the beginning. In India, out of all screened cases, we find 5 to 15 cases positive per 1000 women in pap smear. Now classification. WHO has given the classification in the year 1975. This has been categorized into the following grades: mild dysplasia, SIN 1, moderate, SIN 2, severe dysplasia, SIN 3, as well as CIS, carcinoma in situ. Now, Bethesda system, this in the year 2001, Bethesda has come up with new classification. When squamous cell change has taken place, they call it as a atypical squamous cells. Means they have also discussed it as a ASCES. It is of atypical cells of undetermined significance. And some ASCH means they cannot exclude the high-grade squamous intraepithelial lesion. There is a typical cell but cannot exclude. Then low-grade squamous epithelium, it is called as LSIL. LSIL means WHO, according to WHO, it is SIN 1. SIN 1 and LSIL is the same. LSIL is referred in Bethesda system. Similarly, HSIL is the high-grade squamous intraepithelial lesions. This encompasses both moderate and severe, that is SIN 2 and SIN 3, as well as carcinoma in stage 2. We call it as a stage 0 cancer. So you should just remember LSIL is SIN 1, HSIL is both SIN 2 and SIN 3. So these two classifications, these usually come up as a MCQ question or Viva questions. And next there may be squamous cell carcinoma. Then atypical glandular cells, AGC, this specify endocervical change. Atypical glandular cells favor the neoplasia. Sometimes there may be endocervical adenocarcinoma in situ, AIS, and normal proper cancer of the columnar epithelium or glands, that is adenocarcinoma. But this is very rare, a glandular cells cancer. 95% to 98% we see stratified squamous epithelium carcinoma. Now this is classification of pap smear. How to perform we will see later. This PAP has graded its classification into 5 classes are given. According to 5 classes, the scheme WHO and scheme this Bethesda, we will focus more on WHO and Bethesda. How? Class 1, when there are no malignant cells, means negative for malignant cells, normal cells. Similarly, same is given in Bethesda, they are in normal cells limits. Class 2 pap smear, when atypical cells are found there, but it may be due to inflammation, inflammatory changes की वजह से वहाँ पे cells formation होता है. And then these are in Bethesda, they are called as a reactive and reparative change, means same, ASCES. There may be squamous atypia, squamous atypical cells, and coilocytes. What are coilocytes? This is the change in the cells where there is a in young women due to HPV infection, these cells with the perinuclear halo in the cytoplasm. But you see, these coilocyte cells disappear as the sin advances. Now, class 3 pap smear finding is mild dysplasia, which we have seen it is L-cell in Bethesda. And class 4 is a moderate, severe or carcinoma in situ, which all three are comprised in HCL in Bethesda system. Then invasive cancer are same in both the system, WHO as well as Bethesda. So this is very important. You should remember from Viva and MCQ point of view. Now we'll see how exactly proper visual. See, you can see the Bethesda system and WHO grading. Now SIN1 is normal. Here no change. Normally basal cell, parabase cells, these are the intermediate cells. This is whole is a normal picture. Grade 1 is very mild dysplasia. We call it L-cell, that is low grade stratified intraepithelial lesion. Here you can see 1/3 is the thickness. Basal layer is intact almost throughout the this gradation. See 1/3 thickness of the cervix. It is dysplastic, where whole upper part is normal cells. This is dysplastic, mild dysplasia. And then grade 2 is moderate. You can see 2/3 area has become dysplastic. And this SIN2 and SIN3, grade 2 and grade 3 is comprised with HCL. This is again more thickness is involved with dysplastic cells. Only limited part is normal. And carcinoma in situ, this is the full thickness of the cervix is covered with the atypical cells. So, but basement membrane is still intact. Now, what is dysplasia actually? It is an alteration and disorderly arrangement of the undifferentiated cells. See, there is an alteration in the nuclear cytoplasmic ratio and the cells reveal large, regular, hyperchromatic nuclei with marginal condensation of chromatin material and mitotic figures. This lesion progresses as invasive cancer. This diagram is most important to show how there is change in these cells. You have to draw in exam. Further, we will see the details of it. So this shows that 4% of this reach invasive stage by 1 year, 11% of these reach invasive stage by 3 years, 22% reach by 5 years, and 30% of the cases with SIN reach to invasive cancer till the 10 years of their age. So we can consider that 10 to 15 years earlier, this SIN changes has occurred when woman gets CA cervix later. Now etiology. Most important nowadays, HPV, human papilloma virus, has been considered to be a basic cause. It is considered as a carcinogenic. Now it's low type, low risk type and high risk type. You can remember only high risk type. These are important. 16, 18, 31, 33, 35. These are important types of the HPV infections which may cause possible high risk into the HCL. But according to the age, this also matters that HPV in the younger age usually is a self-limited, but after the age of 30, this may progress into HCL if it is persistent. Coilocytes, these are the cells which are often seen in young women suffering from HPV infection. And these are the cells with perinuclear halo in the cytoplasm. See, this is again a figure showing exactly infected basal cells. If HPV infection has occurred in between the basal cells, this is the HPV infection, then replication takes place in a weeks in the epithelial cells. After 10 to 30 years of the age of the woman, few may change into the invasive cancer if infection is persistent. So if it is not persistent, if age is not much before 30 years, it is self-limiting. So that is important, we should remember. Now, what are the risk factors causing SIN? Average age is 35 to 45 years. Precancerous lesion occurs 10 to 15 years earlier. Coition before the age of 18 years, multiple sexual partners, delivery of the first baby before the age of 20 years. So this used to occur in earlier ages, early marriages, early deliveries, early sexualities. This whole thing works for developing the malignancies. Multiparity with very few spacing between the birth, very poor spacing, poor personal hygiene, lower socioeconomic status also is the responsible thing. Then CA of cervix shares epidemiological feature to the sexually transmitted diseases. Just we have seen HPV is linked here. Trichomoniasis may also cause, if it is persistent, may change the atypical pattern of these cells. Then women who is not attending screening program. This has been important. Nowadays, all over the world, screening program has become the rule, like pap smear. But those who are not following this and those who are immunocompromised, like HIV and all, such female is prone for getting changes in the cancer. Pathophysiology. Now see the columnar epithelium with low vaginal pH changes into metaplasia. If it is a physiological metaplasia, means when there are well differentiated squamous epithelium, nothing to be worried. But if it is atypical metaplasia, suppose viral infections or something is there, then host response matters here. If adequate response, then there is no progression into dysplasia. But if it is inadequate, then dysplastic cells may increase, eventually may lead into carcinoma in cervix and invasive cancer. So screening is important thing. Screening for cervical cancers differs from other cancer screening because there's a well-defined pre-malignant stage of disease which can be easily treated. So cervical screening was first introduced in Finland, Colombia. It is now one of the most successful screening prevention program. How we can screen? Cytology has become important, that is pap smear. This smear method this has been written 51, but it has got 60 to 80% sensitivity and specificity. But most reliable is liquid-based cytology. Nowadays, it was developed to produce more representative sample of specimen than conventional pap smear. And it has reduced the contamination by blood, cells, mucus, and pus. Studies have been reported showing a wide range of sensitivity and specificity. So this liquid-based cytology also hand in hand can be helpful to diagnose HPV infection, as well as genetic studies can be done with these samples. So pap smear diagnosis we will discuss in short. We have seen there are 5 classifications, 5 gradations, and depending upon that, with HSeal and LSeal, it gives you all idea about the pap smear. So normal smear has got parabasal, basal, intermediate and superficial epithelial cells. Sometimes inflammatory cells, dysplastic cells and cancer cells. This has been seen in pap smear. And liquid-based cytology, here the plastic spatula. Here the plastic spatula is placed in a liquid fixative medium, that is buffered ethanol solution. Instead of smearing on a slide, this removes the blood, mucus and all these inflammatory cells. In the methanol solution, it is dipped, then it is removed after few minutes, it is dried and it is again pressed on the filter membrane. And this filter is again pressed on the glass slide. The procedure of liquid-based cytology I am discussing. Here this thin monolayer is then now stained and then visualized under microscope. And we can easily detect the change atypical cells, pattern of the atypical cells in the liquid-based cytology. So diagnosis is depending upon the colposcopy. Once the pap smear shows abnormality, then colposcopy is advised. Colposcopy is advised. This is the colposcope. It's an instrument used to visualize cervix through the cusco speculum. Cusco speculum is inserted first, and then through the scope, the area of the cervix is visualized. Here the aceto-white epithelium is visualized. What is this aceto-white epithelium? This cervix is painted with the acetic acid, and this acetic acid is now changes the color of the dysplastic cells. Here, aceto-white areas appears as a mosaic or punctuation and abnormal vessels. These abnormal areas are revealed under colposcopic study. And colposcopic study, see, the application of acetic acid is done, which coagulates the proteins of the nucleus and cytoplasm, and it makes the protein opaque and white. So this aceto-white, it is called as aceto-white areas, which are visualized then in the colposcopy. Again, it's a clear picture. You can see the 5% acetic acid is applied as it causes nucleoproteins within the cells to coagulate, and therefore the areas of increased cells turnover. For example, syn will appear white. You can see this white area. These are nothing but the dysplastic cells. This is visualized under the colposcopy. You can see mosaic tile pattern. Mosaic tiles, which was used earlier in construction for flooring. So we can see the punctuation marks, commas, or like that, no? So these are the mosaic appearance, which is a confirmation of the syn through colposcopy. So you can also see abnormal vascular pattern like punctuate or mosaicism. I have discussed. This is aceto-white. Now see, this looks like comma, punctuation, no, comma-like appearance and vascular findings. Colposcopy is both diagnostic as well as therapeutic. This is the normal thing, but now you can see change. This is syn 1, syn 2, and syn 3. This is severe grade dysplasia. And in first figure A, you can see this is a squamo-columnar junction where change has occurred. Now biopsy can be taken from the most abnormal site, side by side. So colposcopy is deemed unsatisfactory if transformation zone is not viewed adequate. See, colposcopy is most reliable technique, but still, in cases of menopausal women, this junction is indrawn inside. Suppose if we cannot see this through colposcopy, then further investigations are required. This is the biopsy which is then advised. Before that, endocervical curating. This ASCUS, that is atypical squamous cells, this program of guidelines due to required endocervical curettage in cases when endocervical samples is needed. Brush is sufficient for sampling of endocervical canal. Now normally for cytological study, endocervical scrape is followed by ectocervical scrape. From both the parts, we want tissues to visualize for the examination. And then biopsy is important. If pap smear shows abnormality and colposcopy also confirms it, locates the area, colposcopy locates the dysplastic area, so then we can take simultaneous biopsy through the guided colposcopy. So cervical biopsy is performed at the area most likely to have dysplasia. If the lesion is large or multifocal, multiple biopsies may be necessary to ensure a complete sample of affected tissue. So colposcopy is important nowadays to study the cervix. When pap smear detects HSIL, it locates the area, and it can be also helpful for conservative surgery and follow-up of the conservative therapy. Now, what is VIA? This is the visual inspection of aceto-white areas. Where the facilities of pap smear is not available in rural or peripheral areas, this is applied. Here, VIA is able to select abnormal areas on cervix by applying 5% acetic acid, and the downstaging is done. It dehydrates the abnormal areas containing nuclear material and protein and causes aceto-white change. Just now we have discussed, this is the aceto-white appearance. Then Schiller's test. This is most advanced and important. Here, visual inspection of lesion with Lugol's iodine. Here iodine is painted over the cervix, okay, and these cells contain glycogen. Normal cells contain glycogen, we know. Now they take up the iodine and they turn into mahogany brown color if they are normal. But those cells which are dysplastic, they remain unstained, and biopsies can be taken from unstained area. So you have to understand the difference between acetovite VIA and VILI. That is, this is iodine painted, this is acetic acid painted. White plaque is abnormal, and in VILI, the unstained plaque is abnormal. I hope you understood. Then directly biopsy is taken from this area. So biopsy is helpful to know the atypical cellular pattern changes. Now HPV testing also become important nowadays. This contains the DNA. It is based on the digene hybrid capture. So HPV testing are important finding. 80% of ASCUS and LCIL positive smears are preceded by HPV infections in young women, while 80 to 90% are transitory and self-limited and disappear over the period of 2 years. Only 10 to 20% persist and form a high risk group beyond the age of 30 years. So this is then further done by polymerase chain reaction and culture also. This has become important if there is side-by-side abnormality with the pap smear. Once again, recommendations by WHO. This is a new program. If she is before the age of 30, should start screening from the age of 30 or 35 at least. But they have given existing program should not include women before 25 years. So 30 or 35. Then 25 to 49 years of till 50 years, we can screen if they are found normal. Then 3 yearly screening with cytology is done. And if she has completed her age 50, then if she is found normal, then every 5 yearly cytological study is to be done. After the age of 60, 65, there is no need of screening as such, provided the last 2 smears were negative. So these recommendations we should remember. Course of skin, SIN1 regresses 80 to 90% and may progress 1 to 4% before the age of 30. So this is important. SIN2 and SIN3. This 20 to 40% cases may regress, but 40% or 50% may extend beyond the age of 30, 35 in SIN2 and 35, 45 in SIN3. This is the course of SIN. That's why the pre-invasive screening is important for treatment. How will you manage this management of cervical intraepithelial neoplasia? Whole depends upon the pap smear. See, we have discussed if class 1, if it is found normal, then no need 3 yearly checkup. Normally follow karna hai apne ko. Then class 2, if found inflammatory due to infection, we have to treat the woman for infection and then repeat the smear. If smear found normal, then no need for further checkup. Persistent smear, if it is present for abnormality, then we have to treat her accordingly. Like we are treating for SIN3, SIN4 means we have to plan for further treatments. If SIN3, class 3 may we see SIN1 and LCIL. These you have to test for HPV, follow up yearly. If normal, then okay. But if the infection is still persistent with HCL, then we have to go for further treatment. And SIN4, class 4, SIN2, 3, HCL, of course, we have to advise colposcopy and biopsy. Class 5 is serious invasive cancer. This we have to treat according to the stages. But colposcopy and persistent HPV infection, if they are found, then how will you manage? See, conservative ablation therapies, coagulations by cauterization, cryosurgery, laser ablations, these are advised in cases of SIN1. And SIN2, 3, there is a local excision program. Suppose where we don't find any medical response, definitely whoever pathy you belong, you will try first for medicines and you'll see the symptomatology, whether it is improving with side-by-side examinations and investigations. But if our medicines doesn't help to regress the SIN, Then these are the excision procedures which we can suggest, that is conization, cone biopsy, laser conization. Then this is long large loop excision at transformation zone, LLETZ8. This is again a loop electrosurgical excision program, and this is the again NETS is one of the program where this needle excision of transformation zone is advised, and follow-up is definitely required. Then radical excision, conization, tracheotomy, hysterectomy, with or without removal of vaginal cuff. So this is the follow-up we can advise to our patient in cases of SIN2 and SIN3. So treatment options again we will be revising. In pre-invasive lesions, matlab in SIN. The local destruction is done by cauterization, cryosurgery, this is freezing, and laser ablations. And laser ablations means these are the laser waves which are given, and it has got a less chance of infection, bleeding, and it heals earlier. Laser methods heals earlier. And local excision is advised in SIN2-3, again the same thing. And radical excision is given. Hysterectomy is offered when it has not spread, it is when it is still intact. So these are the treatment plans which are suggested for cervical intraepithelial neoplasia. I hope you guys have understood. If not, you can ask queries, and then we will be looking for proper cancer cervix in our next lecture. Before that, prevention. Depending upon the risk factor, we have to work for prevention. Ask the female to use, husband to use condom, have a contraceptive measure, barrier methods, which will prevent infections, sexually transmitted infections. Then nutrition, dietary changes she should have, her immunity should increase. Behavior changes, okay, we can advise her proper. Then HPV virus vaccine. This has been a new now. The prevention methods are given. HPV vaccine has been working in some places. They are advising because this infection is necessary factor in the development of SIN. It is an important step in primary prevention for the development of prophylactic vaccine to protect against HPV infection. Thank you.